Good afternoon, everyone, and thank you for joining us for our latest Understanding Health talk. Today we're doing a talk from University Hospitals Dorset on hospital at home in East Dorset. My name's James Donald. I'm the comms lead for the trust, but I'm going to introduce you to Karen Bowers, who's nurse practitioner and our UHD Hospital at Home matron, and also Dr. Tom Bartlett, who's a consultant geriatrician for UHD Hospital at Home lead as well. So thank you very much for joining us. Welcome. I'm going to hand over to them now, and they're going to give a presentation, and then we're hoping there'll be an opportunity for questions at the end. So thank you all for joining. Over to you both.
Hi, so as Jamie said, I'm Karen. I'm currently the matron hospital at home. A little bit about me. I've been qualified for just over 20 years. I've got a background of acute medical experience. Started on the acute admissions unit where I got my nurse practitioner's degree. Then I did 10 years of clinical site where I was responsible for covering hospital site out of hours and in hours clinically and managerially. And then I've had matron roles in older persons medicine, medical specialties, and then most recently, for the last 2 years, I've set up our wonderful hospital at home service for the rest of the team.
I'm Tom Bartlett. I'm a geriatrician. I work out of Poole and Bournemouth hospitals. I'm the hospital at home lead, and I've been involved in the project since the start. I also sit on the British Geriatric Society as one of their vice presidents, so very keen on improving care for older people. So what we're talking to you about is UHD at home, or our hospital at home services in East Dorset. Or not? Oh, yeah, they are. So, quick summary of what we're going to talk about. So, firstly, is what actually is a hospital at home? What does that mean? What does that term mean? What have we got here in East Dorset? Because there's not just hospital at homes in East Dorset, they're all over. We're going to then, Karen's going to talk about who our teams are, what we do, what we cover, how it works, what patients can expect, and then back to me just looking at the future of our hospital at home and how we can change things moving forward. Probably the best place to start with what a hospital at home is what nationally the expectation is. So I'm just going to play this short video. I'm going to listen to a bit of this first, which will explain it.
Hospital at home provides acute.
I'm just going to stop it there. So hopefully, now I have to be honest, I couldn't hear that. That sound wasn't coming through. I really hope that sound was working for you. If it wasn't, that video can be found on the UK Hospital at Home Society, and there's a bit more information about it on there. And really, a hospital at home is about providing hospital level care, but in the relative comfort of your own home. And there are lots of very good reasons why that's a good thing to do. And there's lots of very good reasons on how that can work. And there are some other bits that you have to be really aware of, and that might not make it work for you. For us, there's really only two questions. Does the person in front of us need hospital level care? And can anyone else manage that person's care in a better way than we could on the hospital at home? And if they need hospital level care and there isn't someone who can manage it better than us, then actually that's a person who would be suitable for hospital at home. Hospital at home is not a new thing. It may be a new thing for us down here, it may be a new thing that you've heard of, but actually hospital at home has been going for kind of 15 or 20 years. There were a lot more hospital at homes up north of the border in Scotland. NHS England got hold of the idea about 3 years ago, and the ask was that every area, every region would have a certain number of hospital at home beds for their population, and ours were around 70 to 80 beds per 300,000. And what that means for us in Dorset is around the 300, 350 mark. And that's provided across the 3 different healthcare providers that we have in Dorset. So that's Dorset County Hospital over in the west. We've got Dorset Healthcare, which provide those community services, and ourselves here at UHD in Poole, Bournemouth and Christchurch. We now have over 100 beds on the UHD hospital at home. Does it work? So you'd be forgiven for thinking that how can you replicate what you get in hospital in someone's own home? And that's very dependent upon the condition that you've got and what's going on for you. So there will always be a place for hospital level care for certain conditions. So if you have had a heart attack and you need an angiogram, you absolutely need to come to hospital, and that's not escapable. If you need surgery for a certain condition, you absolutely have to come to hospital. If you're desperately unwell and need intensive care, again, that's not something that can be provided in your own home. However, that is a relatively small number of the people who are in hospital. So does it work? Well, yes, it really does. There's lots of evidence out there that, especially in older people, this really does work, and it really can replicate hospital level outcomes for people in their own home. But as we've seen in that video, with less of the more damaging effects that we might sometimes associate with hospital. So as I say, there's lots of evidence in older people, but what we've got, and since COVID, there's been a lot more evidence that this works for everyone, actually, in different conditions. So there's lots of evidence in specific conditions like heart failure or in certain lung diseases. And there's a lot more evidence growing that it can work, for example, if you need antibiotic use at home or for other conditions too. In Dorset, we've got our own unique geography, and that creates some challenges with how we deliver a hospital at home. So there's roughly an east-west split with what we've done with hospital at home across Dorset. In the east, which is where we are, obviously it's a bit more urban than out in the west. And so our hospital at home services are slightly more focused on that and will be focused around ourselves here at UHD. And there is also an older person's hospital at home that Dorset Healthcare are manning. Out in the west, it's a bit more spread out. Again, it's based out at Dorset County. And again, Dorset Healthcare provide a bit of work, but there's not as many beds out in the west as we have out in the east, merely because we've got a bigger population here in the east of the county. I'm going to hand over to Karen to talk about what we really do have here at UHD.
Thank you. So as Tom said, this service makes a real difference to our patients. So I'll go into a bit more detail about the services we offer. At the moment, we've got 5 main different patient pathways. All of these, the teams are multidisciplinary focus. What we offer is what is known in the hospital home world as step-down care. And this is basically early supported discharge when you're a hospital inpatient, which involves our teams supporting you to leave hospital maybe one or two days earlier than you would have done previously. And then you finish the rest of your inpatient stay in the comfort of your own home with the support of our teams. The other service that we offer is what is called the step-up approach, and this is known as admission avoidance and focuses on the team supporting you. Either you could come in by our A&E department or one of our SDEC departments, or your GP could send you in and you're identified by our teams there. And actually, rather than come in to an inpatient ward, the team takes you home onto the hospital at home service, and they provide you with the care you'd receive in the hospital and stop you being admitted to an inpatient ward. The teams that we have are made up of consultants, advanced care practitioners who are highly skilled practitioners that can perform physical assessments, make fully comprehensive care plans, and prescribe medications. We've got nurses ranging from band 5 to 7s, healthcare assistants, physios, occupational therapists, and pharmacists are all part of our team on a daily basis. Looking a bit more into our pathways, we have a child health pathway, which has multiple specific condition pathways, and these allow children to be discharged from wards and our ED departments 24/7 now with how we've developed that pathway. And we also have a pilot project running now with certain GP practices, which means we can take patients straight from GP practices home rather than them coming into our ED departments. The main conditions this pathway looks after is bronchiolitis, which is a common child respiratory illness, gastroenteritis, otherwise known as diarrhea and vomiting, wheezes, and poor oral intake. One of the massive bonuses of this pathway is obviously parents who have got more than one child, and convenience of having their children at home. It's also really good from an education point of view. We find that a lot of parents that have had children on the child health pathway before, it prevents them bringing their other child into hospital, because they find that they've learned how to manage the illnesses better. We've got our respiratory pathway, which is for known respiratory patients that require a bit more support, such as nebulizer therapy, steroids, also IV antibiotics at home. And again, they do the admission avoidance pathway and the early supported discharge from home. And patients can also refer themselves in if they are a known patient to that respiratory team. Our cardiology pathway is for patients with known heart failure, and we support them to manage the fluid that's built up through that heart failure with the correct medication. And we're actually part of a medical trial at the moment using the medication furosemide, which helps offload the fluid. And also for atrial fibrillation, which is an abnormal heart rhythm, and the management of this. The cardiology pathway uses remote monitoring, which I'll come on to later. We have an acute microbiology pathway too, which is for IV antibiotics for infections, and this covers all specialities within the hospital. So it could be anything from a infection on a knee joint post-operation or a chest infection to a cellulitis infection in the limb. And there's various options depending on the type of infection you've got and the type of antibiotic that is required. And this will be discussed with our microbiologist specialist and the referring consultant, and a plan will be made. As a patient, you will have a line inserted that can stay in for a number of weeks. And then you either come back into the hospital to have your medication, we can teach you how to self-administer your IV antibiotic medication, or you can have a pump that you put the medication into and it administers the medication over a long amount of time. So there's a lot of treatment options there, and then obviously you're at home rather than being, in a hospital bed for 2 weeks whilst you need that intensive 2 weeks of medication. So that's a really good pathway for living illnesses. Then we've got our older person services. This is for patients over 75 with a variety of medical conditions. It's a very holistic approach and uses comparative geriatric assessment and the frailty score, and it is one of the biggest pathways that we have. Recently added, and not on this slide, we've got a stroke early supported discharge pathway, and this is for patients post-stroke that still require medical and therapy support, but can have it in the comfort of their own home. And obviously with the stroke situation, being in the comfort of your own home, there's proof that that is a much better place for you to be. And then we are working with the ACTS team, which is our alcohol dependent team, for patients with alcohol dependent and require medical intervention and support detoxing. So I've talked a little bit about our teams. Like to move on. So the teams that we have, they all work in slightly different ways. So here's some pictures of our wonderful teams. That's the child health team and our older persons team. So they each arrive in the day on their base, whichever hospital that is. They work across multiple sites, and the nurses will review the current patient list they've got and their plans for the day, what home visits they've got, which patients need a phone call, which patients are having a video call, depending on, how unwell the patients are. Then there's a meeting with the consultants, pharmacists, therapists, whoever's involved in that patient care. They'll check the blood results for the patients, any investigations they've had. Often there'll be a phone call to the patient that morning just to check they're okay, nothing's changed overnight. And then they'll arrange a visit. Some of our patients, I went out the other day with the elderly care team, and one lady doesn't like to get up before 11 o'clock, so we didn't go to her till after 11:30. And then they'll review any referrals that have come in to be screened and kind of delegate the workload between the teams. We also obviously have to identify our patients that are going to be admitted that day. So again, we will visit wards on the departments around on the hospital site across Bournemouth and Poole, and screen patients on the wards and on our admission areas in the emergency department, and admission areas to see what patients are suitable to come into the pathways and meet our criteria to help with the pressures, and get suitable patients. And that involves attending ward rounds as well. We'll have patients come in obviously for their IV antibiotics, and then we'll go out and actually visit the patients that require the visits, doing a full assessment, reviewing their history, doing a medication review. A lot of patients go home with a lot of medications, and we need to change the doses, make sure they're on the right dose, not too high, not too low. Often with cardiology and the fluid management, we'll need to titrate that dose up and down depending on how it's working. We need to take bloods to see if infection markers are going up or down, and then make a plan for the next 24 hours. Might need an urgent investigation then if the patient's not too well. We have the ability to order x-rays that can be done that day, get the patient straight into the hospital. They can have their chest x-ray. We have results back within a couple of hours, ready to review and then make a plan. And we can also make referrals for urgent physio OT and order equipment. We'll then feed this all back in the afternoon or whenever to the consultant and have a discussion, make any clinical decisions, chase the results back, and make sure we've got the right clinical planning for that patient. Do they still need to be on hospital at home? Can we discharge them back to the care of the community, the GP, or just fully discharge them with no follow-up? Actually, are they getting really, really sick and they might need to come back in? And then new admissions will come in. We might need to go back out and do more clinical visits. And then we'll do plans for the next day and how the next day's caseload is going to go. So what it's like being a patient on the hospital at home. Well, you get up in your own bed at the time you want. You have your breakfast. If you're on the remote monitoring, you take your observations and record them on the app, and I'll come on to remote monitoring shortly. The hospital at home nurse will call you, ask you how you are, tell them what time that you're coming. Obviously, if you feel really unwell or you've got any concerns, you've got how you can escalate before we come and visit. So there's always a number for you to call 24/7. There's an hour, out of hours procedure, which is all on a leaflet given to you. The visit with the nurse lasts as long as it needs to. It can be 10 minutes, it can be half an hour, it can be 40 minutes. It depends on what you need and the clinical needs of you and the conversations. And then the nurse will obviously follow up that day, call you later on if there's blood results needed, if there's any investigations, if there's medication changes needed, or they need to order you any medication that we then get delivered out to you, and make sure you understand the plans that are going through. So we do have remote monitoring, and this enables you as a patient to go home and take your observations as you would have done in hospital. This is your blood pressure, your pulse, your temperature, and the level of oxygen in your blood, which is obviously what the nurses take when you're in hospital. So we provide you with the kit as seen in the box here. The team will talk you through how each piece of equipment is used and make sure that you are happy and competent to use it yourself, and that you understand how to use equipment, or that you have a carer next of kin that's happy to use it, and that you understand how the readings go. There's a digital app that goes with it, which you could download onto a phone or a tablet. And then you will need to, again, our teams assist you with all of this before you leave the hospital. And then tell you how many times you need to record this. So for some patients, it's once a day, some patients it's twice a day, and some patients it's 3 times a day. but you'll be informed all of this, and then the time frames that you need to put it in. And normally it's an hour window, so it could be 9 till 10, and then 12 till 1, and 4 till 5. But 3 times a day is the maximum you would need to do this. And then a remote monitoring team works alongside us, keeping an eye on all of the patients we have on remote monitoring. They will contact you if there's any concerns with abnormal readings, check you're okay, and then liaise with us, and we will make a plan. Obviously, if you're feeling unwell again, you let us know straight away. So that's a really good add-on that works with our service, with alongside everything we're doing. We can keep an eye on if your blood pressure is a bit low, a bit high, what the medication is doing with you, and that works alongside the service. And most importantly, what do our patients say about the service, our patients and carers? Patient feedback is currently very good to excellent. And this is from our Trust Friends and Family survey, which we do monthly. And we do get a good number of responses on that. In the speech bubbles are some of just the lovely comments we received. Service is very good. Nurse came every day, wonderful experience. Wouldn't have managed without my help, first class service. That's exactly what we want to hear from our patients. That's what we're here for. So that's fantastic. We also participated in a national benchmarking event last year, which was against other hospitals. And the results were really positive from patients and carers, and we actually were rated higher than the other organisations that we pitched against. And the recommendations would be recommending our services to others, how we explained about the equipment worked, and that they would use the service again. So that's really good. I'll now hand over to Tom to tell you a bit more about what our aspirations are for the future.
Thanks, Karen. So you can see there's huge amounts that we're already doing, but we know that other parts of the country and other parts of the world are doing different things, and there are other things that we think we can do here, and we really need to get going. So these pictures are kind of part of some of those ideas. It'd be lovely if we could provide home oxygen for people, and I think that'd be quite a big boost to some of our respiratory pathways. One of the things we're looking at and nearly being able to do is doing things like IV fluids, so fluids into your arm or your vein, like you might have in hospital, in your own home. And this also ties in with the antibiotics or with other medications that you can only really give through a line in your arm, and it's how we manage that. We need to really work closely with some of our partners, and certainly the ambulance service are brilliant partners, and there are lots of patients who they may see at home or in their care home or wherever that person might be that actually might not need to come to hospital. So how do we work more closely together with them to avoid that person even turning up in the emergency department? So how can we save all of that time and possible discomfort for the patient of having to wait in ED in the emergency department, and how can we get our teams out to see them? At the moment, we haven't got any surgical pathways open, although we are discussing with surgical colleagues about how we do that. So that might look like, if you know that there's an operation coming up, rather than coming in a day or 2 days before the operation to work up before the operation, can we do the hospital at home service and have you coming in just on the morning of the operation? Equally, could you go home a bit earlier after the operation or have your antibiotics at home following your operation? Lots of different ideas there. In the bottom left-hand corner, there's lots and lots of kit available for this. So there's things called point-of-care testing, which is where we can get blood tests for you, and you can put a point-of-care testing machine in the back of a car, and then we can have a look at what's going on. What this picture shows is actually an ultrasound machine that you can use on people. Again, just with a smartphone, you can see what's going on, and that can mitigate the need for lots of other tests or diagnostics and help you make the right decision for that person there and then when you're with them. So there's lots and lots and lots of movement and potential with what we could be doing. And really, there isn't really an upper limit of where we could go and what we could do. It's just about how we make it all work for people and how we make sure that what we're doing is right and right for each person that we see. I've mentioned that lots of this is about tying together with our colleagues across Dorset. I've already mentioned the ambulance services, but if you remember back at the start when we were talking about who is doing what across Dorset, this very much has to be a joined up enterprise with Dorset County and Dorset Healthcare, and we have to all be trying to work together and do things for the benefit of everyone. And it's how do we share the responsibility for people? How do we make sure there's not lots of different teams calling in on the same person on the same day or on other days, and how we communicate to each other? And this is another big bit of work that's going, and believe it or not, it's not always the most straightforward part of the work. It's actually sometimes some of the more challenging, where you've got computer systems that don't quite talk to each other and things like that. But they're all things that are invaluable to make sure that we're doing what's right for that person at home. So finally, I hope what you can see is that the UHD at home provides increased choice. It provides autonomy, your chance to say what you want and when you want, and comfort of the home. It can help minimise a lot of the hospital-associated harms, including deconditioning or depression or hospital-acquired infections that people can sometimes get in hospital. The potential for this is somewhat unlimited, and our hospital at home will grow. The need for the hospital buildings will always remain, and the number of people using hospitals is going up. So I don't think this will reduce the amount of beds we have, but it will give people greater choice. And it's not for everyone, and it's not for every condition, as we've seen. And for some people, it might not be what they want, and that is completely fine. But I do think it's for a lot more than we currently think, or that you may think. Thanks very much.
Fantastic. Thank you very much indeed for that talk. I'm going to stop sharing now so that we can see your faces. We've had a bit of problem with the Q&A. So if you've got any questions, if you could email them to, I've got some questions that were emailed in advance, so I can go through them. But if you've got any questions, please message my colleague Melanie Croydon. So that's Melanie, Melanie, .Croydon, Croydon, @uhd.nhs.uk. That's melanie.croydon@uhd.nhs.uk. But I've been sent some questions in advance. If I can run through those with you, that'd be fantastic. How can you be sure that patients receive help if they suddenly deteriorate? Sorry, I can't read their writing. So if a patient suddenly deteriorates, how do we know that we can get them help in a timely fashion?
So we have had this happen, and if they have obviously got a relative with them, we always advise that obviously if they have a relative with them, then it's just call 999 like you would anyway, because that's going to be the quickest response that you can get. If we are with the patient, we would do the same. We would call 999 because that's the fastest way to get a response. If the patient is on their own and they start to feel unwell, we would advise them exactly the same. Call 999, and that's the response for everybody. And I think that's the caveat we've got. If they feel unwell out of hours, it's the same caveat. They can call us, and if they feel unwell, we'll, they've got all the contact numbers of the team that they're under. And if we will do, that first assessment on the phone, but even if we think they sound too clinically unstable, by the time we maybe get 20 minutes to get there, we will advise them to call 999 straight away. If we think from just what they're telling us over the phone that, by the time we get there, we're not going to be able to add anything, because it's all about safety and risk. And the patients that we take out have to meet a set criteria. So we're not taking out the sickest patients in the hospital. We are taking patients out who meet a set criteria that are safe to come into the hospital at home service. And the ones that are more acute than well are the ones that are on the remote monitoring. So we know what their observations are doing, and they're having home visits, so we can kind of detect, they're having gloves on them as well, so we can hopefully kind of pick up the early signs.
Yeah, so regular monitoring is really important for that. You mentioned you can phone up. Can people sort of phone up 24 hours a day at the weekends and things? What's the sort of the time of this?
So the gold standard hospital at home service is 8 till 8. Most of our services run 8 till 6, and then out of hours, all hospital at home calls go to 111. Got an agreement that the patients say they're on a hospital at home service, and then they have an algorithm they follow, because obviously patients on hospital at home are deemed as inpatients. So then obviously they will get priority.
Fantastic, thank you for that. This question, actually, you've answered some of this, but we'll go through it anyway. What plans are there to use technology to help? This person's heard about a device that that records if someone uses a kettle in the morning to make sure that they're up. So if they don't turn on the kettle by 10 o'clock or something, I don't know if you've ever heard of that, but
Yeah.
using technology, what other technology, not just to sort of record how they're feeling, but also to check that they're there, etc.
So I think there's a couple of different ways to think about this. So one is to start off by saying that hospital at home is for those people who would otherwise be in hospital. And there's a lot of technology out there that is as much about welfare technology. And this is what I think you were describing, James, with the kettle. So there is quite a lot of technology that checks if someone's turned their light on that day, or if they turned the kettle on that day, or opened their fridge, or things like this. And it can detect temperature or pressure drops in someone's home. The other way technology can be used, for example, with false alarms, and lots of people may have already seen false alarms. In terms of hospital at home, lots of the technology centres around the remote monitoring, which Karen's already mentioned. And I also mentioned some of the technology advances in terms of how we can diagnose what's wrong with someone by seeing them at home. And that's the point of care testing, which is blood testing, and also ultrasound scans and other bits. It's by using these bits together that then give the whole and kind of better picture. Technology is a really, really useful tool, but it doesn't yet replace kind of the human interaction, the human touch, and also the human decision making. So it's just another tool that we've got that help us make the right decisions.
Brilliant. Thank you for that, Tom. Another question, this is one that appeals to me as someone who lives in the country. Remote monitoring, what internet does it require? Because some people don't always have the best service. So what sort of bandwidth or whatever does it require?
That is one of the limitations. It does require internet connection because it does work off a mobile app. What we do have, one of the caveats we have is the remote monitoring team, they can phone the patients. Again, the patient does need to have obviously a telephone number, but it can be a landline if people still have landlines, or a mobile number. That's how we're coming across that at the moment, because obviously we're very conscious about health inequality with the hospital at home and making sure that, we're as accessible to as many patients as possible.
And I'll just add to that we saw, when I showed the picture of Dorset and showed the kind of the population spread, we're fully aware, working with in the wider kind of Dorset spread, that an awful lot of Dorset is countryside. Most of Dorset is countryside. And so actually it's really imperative that when we're designing all these services, that it is open to all, and it's how we make sure that it's accessible to all. But there are some limitations based on the companies that just don't work if you don't have a good broadband connection, but it's how we then find ways around that to make it work for those people.
Thank you for that. That was a reassuring message. This is a slightly sort of interesting one. Someone's asked, is this just money driven?
It's when you hear the patient feedback, and it's trying to offer patients an alternative to being in a hospital bed. And like Tom said, it isn't for everybody. But when you go, as I said, I went out last week with the frailty team, and when I saw some of those patients, I've done frailty, so it's a particular passion of mine. But when I saw two specific patients who were in their 70s in their own beds with their next of kin, they've been able to see their family, and they were comfortable in their own beds, and they were both quite unwell, one following about a flu and one with heart failure. And we did have to take blood. One lady had to go in for a chest x-ray. We were able to keep her at home, but they were so happy and to be comfortable in their own beds, even though they weren't sleeping well. And one of the lady's husbands was feeding her fantastic food, which she was very grateful for, because what she ate in the hospital hadn't been doing her well. She'd been losing weight. That's what it's about for me and the nursing staff. And the nursing staff love working for the service because they can spend more time with the patients. So for us and the teams, it's definitely not money driven. But if you want to add anything,
I guess only that. Can it save money? Yeah, it can save money. But that's not the primary reason for doing it, as Karen said. But anything that can improve conditions for people who are unwell, and if it saves money as an add-on, that just sounds like a bit of a win-win, really.
And it does free up space. You know, we have patients, you hear it in the news every day, ambulance can't unload at the front door, we're nursing patients in our corridor. If it frees up the patient out of A&E that we can take home with hospital at home, rather than them sitting in that A&E waiting for a bed they don't need, or we can free up a bed downstream by taking somebody home earlier, so a patient that does need it can then be admitted. That's the right thing to do.
I think you just read my next question, Karen. It was about what somebody's called bed blockers, but we may not use that term. But I think you've answered that one beautifully.
These patients are bed blockers. It's just looking at delivering their care in an alternative way.
Exactly. So
they're still medically unwell.
Yeah.
These aren't medically fit patients. These are patients who still require care and would otherwise be in an inpatient bed.
Perfect. Thank you for that. There's another question here that's come up from the remote monitoring, because you sort of showed that little box and everything. How accurate is that kit to use at home?
So it's the kit we would use in the hospital, same thermometers that we would use in the hospital. It all has to go through a procurement process. It all has to be tested before we can give it out to patients. The blood pressure cuffs, again, they are ones we would use. So it's not just stuff we go onto, you know, the internet and buy. It's all PAP tested, etc. And like I said, we teach the patients to use it, and the nurses check that the patients are using it correctly. If we get what we feel is like an abnormal reading, we will ask the patients to repeat it. And if we're, you know, really concerned, we will obviously send somebody out to double check or do like a series of questions of how is the patient feeling. And we can always issue new equipment if we're, you know, test the equipment to make sure that it's not faulty.
And there's a question coming about your future development plans, because it sounds an amazing thing. What's sort of holding you back? Would it be staffing to make sure it's an accurate and safe service, or what sort of holds it back from more, or there aren't enough relevant patients for it? What's holding you back there?
So I think that's a really good question. I think there are a few different strands to that. So we know that this is a big push for how healthcare is going to be delivered in the future. It's about blurring those lines between people, between GPs, between people in community, and between people in hospitals, and it's how we deliver that. But that does create some problems, and that creates, as I kind of mentioned, it creates those problems with, well, how do we all communicate together as healthcare workers? And that's not always straightforward. And because of things like information governance rules, and patient safety, there are some limits to how quickly you can move that. One of the other issues, well, the main issue really is there's no extra money to do this. So it's how do we change our services and show that we've got that change to generate the money to do this again in the future. So there was a bit of money initially to start it up, but since then it has to be self-reliant. And that creates a challenge, because how do you create something new and build it without those building blocks in place? Part of those building blocks, which is the other big bit, is how do we have the money to get lots more staff to do this work? People love doing it when they do it, but you have to get the people to do the work. And you've seen all the headlines with trying to get people to work in the NHS, is that there's a lot of shortages.
Brilliant. Thank you for that. Thank you. We've got a question here from David. You mentioned patients going to hospital if they need an X-ray. Is there a mobile unit that can take X-rays at a patient's home, CT, etc.? I know you showed that chart with on his back. What's the sort of the limitations, and what sort of tests can you do on those things at home? Thank you, David, for your question.
So CT is not something that's portable, and neither are MRI. X-rays, there are portable X-ray machines, but they're about the size of the kind of back end of a car. That's not something that we could do, and I don't think they work outside of hospital spaces anyway. The little machine I showed was a little ultrasound, and so for some things, actually that can give you a good idea of what's going on. It's not quite as specific as a X-ray or as a scan, but in some instances it can replace the need for it. What we try really hard to do, though, is that we work kind of hand in hand with, you might have heard of things like the SDEC services, same day emergency care, where we can get people in that same day to have the tests that they need and then back out again. And by us working together with those teams and working hand in hand, actually that's much more seamless. And so we can plan those investigations for people. And that makes it much less painful of having to come in and wait for all those tests.
Thank you for that. There's another question here. The monitoring equipment, we've talked about that. Does the monitoring equipment automatically talk to the server, or does the patient have to send the readings in? Does the monitor remind the patient? We all need reminding. Does it actually remind the patient as well?
So the patient has to have a app on their mobile phone or their tablets and put the readings in manually, but the app on the phone reminds them when the observations are due. If the patient can't do that, then the remote monitoring team who work at Dorset Healthcare and work alongside, they will contact the patient and can take it verbally over the phone and then input it into the system. So there's kind of two ways around it. Ideally, the patient should be able to put it in the mobile application themselves, and it's a very easy, user-friendly app. And it's just a scroll system and follow the instructions on the app. But again, the nurses, the hospital at home team download all that onto the phone with the patient, teach them how to use it, or with their carer next of kin, to make sure they're comfortable and able to use that. And if they're not, we talk to the remote monitoring team about how they can be helped with it, or if they can't use it, then obviously they're not appropriate. We wouldn't send somebody home with remote monitoring if they couldn't use it and it wasn't safe. That, that's not an option on a safe service.
Another question's come in. How prevalent is this service across the country? Is it sort of pockets of excellence, or is it sort of becoming much more national? Is it in Scotland, Wales, Ireland, Northern Ireland?
So it's everywhere. So as I mentioned, one of the early slides was mentioning that there was a drive to have hospital at home services available to everyone across the country. That doesn't mean they're all the same. They're all really quite different. In some areas, it will just be available for older people. In other areas, it will have a very different look to what we have here. Some areas are more advanced than we are here. Most areas aren't, I would say probably don't have quite as many options as we do. So it's a big variety. But the general rule is there are hospital at home services available across the country.
Got my mute. Brilliant, thank you. Well, we're sort of nearing the end of the talk. Thank you for the people who've been messaging in questions. It's really appreciated. Is there anything you two would like to sort of, as a final thought on hospital at home and why you're excited about it, just to sort of remind us of and your hopes for the future, just to summarise the today?
I think for me, for people to publicise the service to friends and family and to ask about it when they're in the hospital, is it available, if they're interested about it. And I just hope we can continue to grow and have more pathways and services so that our patients do have more options to being in hospital.
So if people have questions, please by all means contact us. I think we're available on the webpage, the UHD webpage, so you can look us up under Hospital at Home. So it's just very exciting. I think you'll see these services growing quite a lot more. I certainly hope you do. And hopefully, if you need us, we'll be here and we'll be looking after you.
Fantastic. Thank you both so much for that, and thank you all those who have joined. I've got a message about if anyone's interested in talking about the 10-year plan. We're going to leave this meeting and go to a new place. So the message is Mel's online, so she can step in if I say this wrong. We can do a webinar about the 10-year plan. For those who want to come, and please do come, because it's really important that we all feed back on the 10-year plan. If you click on our homepage, which is www.uhd.nhs.uk, you fill out your email address. Sorry, where do they go then, Mel? Can you come on and explain for us?
Yeah, of course. So on the homepage, there is a slider at the top, and basically it says join the interactive workshop by clicking here. So you click on that, it will come up with you need to fill your name and an email address in, and you submit that, and then within a few minutes, I've just done it myself, so it takes a couple of minutes, you'll get an email which will have a link to the webinar, and we will see you on there. Perfect.
So it just remains me to say thank you to Tom and to Karen for that really interesting talk on hospital at home. We look forward to hearing more about it in the future and publicising it more as well. We need to be doing that because I think when people hear about it, they might have a few reservations the first time they hear about it. So you two were fantastic at reassuring people. So thank you both so much for your talk, and thank you for your time. Thank you for everyone who's joined. I hope to see you on the webinar. Shall we say in sort of 8 minutes or something, Mel? What do you think?
Sounds good. Sounds
Perfect. Thank you all very much indeed. Thank you.
Thank you.
Thank you.
good.
Bye.
Bye.